Good afternoon, Dr. Sanu Sarkar. So you're muted.
Yes.
Good
Good
afternoon.
afternoon. Good afternoon.
So I am Dr. Charu.
Yes.
And right now, I mean, the first program from 4 to 4:30 would be in Hall A, the case-based discussion. And then
Yes.
we'll come to the Hall B for our sessions.
Okay. So first, the program will start at Hall A.
Yes, sir.
Okay. So we can attend the Hall A for that half an hour.
Yes, sir. Yes. From 4 to 4:30, we'll be attending that. And then we'll come back to our Hall B for our program.
Okay.
Yeah.
Thank you.
Okay, sir. Welcome, sir.
हेलो हाँ जी हाँ हाँ जी हाँ जी वो उससे भी फोन आया था, पता नहीं क्या कर रहे हैं वो। मैंने अभी लिंक पे तो कर लिया है, मैं अभी वो देख रहा हूँ। आई एम जस्ट ट्राइंग टू फिगर आउट कि वो नहीं, आई कैन सी माई सेल्फ बट आई कैन नॉट सी एनीथिंग एल्स। वो भी मैं उसको फोन किया है। हाँ, आई कैन ओनली सी माई सेल्फ एंड अभी कोई और आ गया सर, आया अभी कोई। ओके सर।
Hi, Dr. Navneet. We can see you. We can hear you. Dr. Parikshi?
Okay, sure.
Yeah.
Hello.
A very good afternoon to everyone. So I welcome you all to the NALCCon, which is the 10th annual conference for Indian Society of Study of Lung Cancer. So for the first session in Hall B, I will like to invite our chairperson for today, Dr. Shamal Sarkar. Sir is the leading pulmonologist in Ranchi. So, sir is a leading pulmonologist in Ranchi, and he has a special interest in sleep apnea. So, I would like to invite sir to introduce our panelists for the first session. Sir, over to you.
Thank you very much. And as all we know, that the 8th edition of TNM classification is being used all over the world to classify the lung cancers. And our first topic is regarding that TNM staging system, the practical aspect of TNM staging 8th edition. And the speaker is Dr. Vikas Talreja. Vikas Talreja from Delhi. And can you put more details about the introduction of Dr. Vikas Talreja? Vikas Talreja is consultant oncologist, Safdarjung Hospital and Bardhaman Medical College, New Delhi. So I would like to request Dr. Vikas Talreja to please start your talk on practical aspect of TNM staging, the 8th edition. Over to you, Dr. Vikas Talreja. The stage of yours.
Thank you. Can I have my slide set, please? Thank you, Dr. Shamal sir, for a kind introduction, and welcome everybody for an visual academic feast. Everybody is in right now for a great academic discussion, and we need to kickstart the session right on time. So I won't be debating much. Is there a team where I can have my slide set? Or I need to share my screen?
Better you share your own screen.
Perfect. It will take some time for that.
Sonali, please give Dr. Vikas Talreja the rights for screen sharing.
Is it a problem for you, Dr. Vikas?
Yeah, there is. I have.
Shalu, can you hear me? Please give him the rights.
Ma'am, he already has the rights.
Okay, Dr. Vikas. You can share your slides.
Perfect. Perfect.
Do we need to make him the co-host?
Ma'am, he's already in the panelist column.
Okay, fine.
So you're able to share the screen?
Hello. Give me 10 seconds. I can. Give me just. Can we mute the other people? It's
Sure, sir.
सर मैं ना देखो जैसे डॉक्टर सज्जन है उनको मैं ट्रेंडी बना रही हूँ अब इनका भी
is the screen visible right now?
Yes, Dr. Vikas.
Perfect. I will make it full screen right now.
Yeah.
That's fine. Perfect. So the topic has been how to identify the advanced cancer, what the recent advances is, and I will be sticking very basic to the points so that we carry home message. We all know why staging is necessary, why cancer staging, especially the lung cancer, because there has been a survival as well as predictive and prognostic changes across with each upstaging or downstaging of it. And you could see that a properly staged cancer has properly staged cancer, that is stage 1A1, has a 5-year survival of more than 92%, and stage 4B has a 5-year survival of 0% when it was initially proposed. And this is how the staging usually we see. As the stage increases, we know the virulence of the cancer increases, and from 5-year 92% survival, it goes back to 0% survival in stage 4A and stage 4B tumors. So first comes the nodal staging. Why the nodal staging is that much important? It marks a very important for a resident also, and for a clinician, and for the oncologist and the pulmonologist, no matter whoever it is there, it is very important to know these node stations. It is in our basic curriculum, but again we tend to forget it as we tend to move across the curriculum. Level 1 is the lower cervical, supraclavicular, and the sternal notch nodes. The upper zone, the superior mediastinal, we divided into the paratracheal, right and left, the prevascular, the retrotracheal, and as well as the lower paratracheal lymph nodes, the right and the left. The fifth and the sixth goes to the AP zone, where there is subaortic and the para-aortic group of lymph nodes. The carinal lymph nodes and the paraesophageal lymph nodes goes into the inferior mediastinal group of lymph nodes. So as when we say that it's a N1 node, we need to know what exactly is the N1. N1 are usually the hilar or the interlobar nodes. In case of a segmental involvement, it's the lobar or the segmental involvement of the nodes that is known as the nodal station. And just for overview, when we say carcinoma in situ, everybody knows that T1A is that what is less than 1 centimeter. T1B is more than 1 centimeter and less than 2 centimeters. T1C is more than 2 centimeters and less than equal to 3 centimeters. Anything with an invasive component of less than or equal to 5 millimeters is known as micro invasion. It should be millimeters. The T2 descriptors involves three major things: either the involvement of the main bronchus, as you can see from this, then T2A is more than 3 centimeters and less than or equal to 4 centimeters. T2B is more than 4 centimeters and less than equal to 5 centimeters. The T3 descriptors are again uh, predominantly based on the size, when it is more than 5 centimeters and less than equal to 7 centimeters, with the involvement of the parietal, pericardium, or the phrenic nerve, the involvement of the chest wall, or the second nodule in the same lobe is T3. When the size increases more than 7 centimeters, or there is an involvement of the mediastinum, there is involvement of the trachea, carina, heart, great vessels, recurrent laryngeal nerve, esophagus, vertebral body, or there is an involvement of the diaphragm, or there is a second ipsilateral nodule but in a different lobe, then it is known as a T4 lesion. Similarly, for the N1, as I said while describing the nodal stations, anything which is intrapulmonary, peribronchial, or hilar lymph node is an N1 lesion. Anything which is mediastinal, ipsilateral, and the subcarinal lesions are the N2 lesions. The contralateral hilar or the contralateral mediastinal, even the scalene, whether it is ipsilateral or the contralateral, the supraclavicular contralateral lymph node is an N3 lesion. And when we describe M1, M1 is simply when there is a nodule which is on the opposite side, or that is a contralateral lung nodule. There is a pleural effusion which is documented cytology positive. There is a pericardial effusion that is documented cytology positive. So that's an M1A. The M1B is a single extrathoracic metastasis. The M1C can be multiple extrathoracic metastasis. So when we say extrathoracic, what are the common sites where these diseases go? Brain, bones, liver, adrenals, and kidneys. These are in the hierarchy order where they go. So just to recapitulate, anything less than 3 centimeters is a T1 lesion, which is surrounded by the lung or the visceral pleura without invasion, more proximal than the lobar bronchus, with T1A less than 2 centimeters in diameter, T1B more than 2 centimeters but less than 3 centimeters in diameter. T2 is between 3 to 7, 7 including, involving main bronchus, invading visceral pleura, or it is associated with atelectasis or obstructive pneumonia, with 3 to 5 being T2A and 5 to 7 being T2B. T3 is anything which is more than 3 centimeters, invades chest wall, diaphragm, phrenic nerve, mediastinal pleura, parietal pleura, main bronchus with less than 2 centimeters from the carina, atelectasis or obstructive pneumonia of the entire lung, and the separate tumor nodules in the same lobe. Anything that is involving mediastinum, heart, great vessels, trachea, recurrent laryngeal nerve, esophagus, vertebral body, with separate tumor nodules in the different lobe is T2, T4 lesion. So N1, as we said, it's an ipsilateral peribronchial hilar. N2 is mediastinal subcarinal. N3 is again contralateral mediastinal, contralateral hilar, ipsilateral or contralateral scalene and supraclavicular. M1 is, as we discussed in the previous M1 classification. Now, this is a comparison of what was the AGCC 7th edition and what has been the AGCC 8th edition. So what has been a T1 lesion, that is T1A and T1B, was in 7th edition, that is less than 2 centimeters or 2 to 3 centimeters. Here we have hierarchy into 3 subgroups, A, B, C, that is less than 1 centimeter, 1 to 2 centimeter, 2 to 3 centimeters. The T2, which was 3 to 5 centimeters and 5 to 7 centimeters, has been a T2A, central visceral pleura, with 3 to 4 or 4 to 5. Now, this, the 3A, when we call, that is T3 and 1, that is more than 5 to 7 centimeters with a node involvement. Here, the T3 is more than 7 centimeters. So what was 2B in this? That was T2B, that is anything between 5 to 7 with a node involvement. Here it is much smaller. The lesions have become much smaller, 3 to 4 or 4 to 5, again with a node involvement. And what was still a 2B, that is between 5 to 7 centimeters, has become upgraded to 3A. Now, ipsilateral nodule and invasion was T4. Here the size also has been introduced, because anything more than 7 has a consequences, and that has become a 3A in this classification. And that's why what was 3A in this, it was anything that is T3 and 2 or N1, that is the invasion, the satellite, or more than 7 centimeters. Now 3B, it has become in this, that is anything that is N2, size of 5 to 7 centimeters with invasion and satellite, it has become N2. Now anything that is N3, here was 3B. There was no thing such as 3C there. Now the 3C also has been introduced. So we have a prognostic significance of that also in this. And that's why when we staged lung cancer, according to the old, it was 7 categories. Now we have 9 new categories with the introduction of 1A into 1, 2, 3, 3 into ABC, and 4 also into A and B. And all of these
Dr. Vikas, sorry to interrupt, but we are short of time, 3 minutes. So please, if you can do a bit.
Yeah. So just 2 slides more.
Yeah.
So staging now, it stage 3, which is very important for the medical oncologist per se, also has now a 3A-B-C, which means T4N0 is stage 3A, T3-4 is N1 is stage 3A, and T1-2 and N2 is a stage 3A, and T3-4 with N2, T1 or 2 to N3 is again 3B, and any T3-4 with N3 is again N3. The investigations which we look for the staging is the bronchoscopy, PET scan, EBUS, and mediastinoscopy. And I would skip these slides for the sake of the time. We know that that's going to come. And just a quick word, what are the risk factors for occult N2? Anything that has been a central tumor, the size of the tumor, and higher SUV values on PET is there. So I would like to conclude and would take any questions if there are for me.
Yes. Thank you, Dr. Vikas. Though it becomes a short of time for you, but it is an excellent presentation for the practical aspect of TNM staging. Now, the 8th edition of TNM classification is being used all over the world. And the 9th edition is expected to be published in the year 2024. The 9th edition will provide much better staging and clinically relevant prognostic grouping in the lung cancer patients. But this is a huge challenging task for the thoracic oncology communities around the world to prepare the new classification. Now, to address this, our next topic is towards the 9th edition of TNM classification, and for which we have Dr. Navneet Singh. Dr. Navneet Singh is Associate Professor at the Postgraduate Institute of Medical Education and Research, Chandigarh, and also Secretary of ISSLC. Now, I would request Dr. Navneet Singh to please start your talk on the topic. Over to you, Dr. Navneet Singh.
Thank you. I need to do screen sharing.
Okay.
But somebody needs to allow me to do that.
Yes, you can do it quickly. It will be better to control for you.
No. It says you cannot start screen share while the other participant is sharing. So
Okay.
Sonali, can you please help Dr. Lamneet?
Ma'am, he has the rights. He can share the screen.
Sir, you have the rights now.
No, it
Other
says
person.
you cannot start screen share while the other participant is sharing. Okay.
Your on the panelist column, you can use your rights, sir. Yeah.
Yes. Yes. Yes.
Okay. Is it
Yes.
visible and audible?
Yes. Yes. Make it full screen. Yes.
Right. Okay. So, the topic allotted to me was TNM staging, working towards the 9th edition. I have no disclosures. Let's start with an illustrative case scenario. There's a 63-year-old male office employee who is a chronic smoker with a smoking index of 700, which is equivalent to 35 pack years if you take Western standards. Presents with pain in the right shoulder and the right upper limb for 6 months and swelling of face for the past 2 months. Clinical evaluation reveals a Pankos syndrome and superior varing cable obstruction. And if you can see the CT scan here, this is the mass, which is 4.2 by 3.7 centimeters in the right apex. And you have 2R and 4R lymph nodes, which are the ipsilateral mediastinal lymph nodes. And the image guided biopsy from this mass reveals non-small cell lung cancer with strong P40 positivity on immunohistochemistry, making it a squamous cell histological type. So the question is, what is the TNM stage? Would you classify it as T3 N2 M0, or would you classify it as T4 N2 M0? Because we know by the dictum which has been taught to us that anything which has a SVC syndrome is a T4 lesion. So I know this is not live, so people cannot really reply. Hence, I will move forward. So if you look at the staging manual, it says that if you have vocal cord paralysis from right recurrent laryngeal nerve involvement or superior cable obstruction or compression of trachea or esophagus, this can be due to the direct extension of the primary tumor or to lymph node involvement. If it is due to direct extension of the primary tumor, only then is it classified as a T4. If the tumor is peripheral and the vocal cord paralysis or the SVC is because of the presence of N2 disease, it should be classified as such. So in this case, there is bulky mediastinal lymph node which are causing the SVC, not the primary tumor. And for staging purposes, it remains N2 and the T stage is actually T3 and not T4. And therefore, this is a T3 N2 M0. But the story does not end here. Do we know whether the survival from SVC obstruction or recurrent laryngeal nerve palsy differs if it is caused by the primary tumor versus if it is caused by the nodal disease? We don't. And so in my talk, I'll talk about the staging issues. Firstly, introduction. Secondly, the potential lacunae at the 8th TNM. And third, a little bit about the individual T, N, and M descriptors. So this is the staging manual for thoracic oncology, the 8th edition, the editor of which was Dr. Raman Rami Porta, the past chairperson of the staging committee. Just a quick recap. We all know that stage descriptor means look at T, which is tumor or the local spread, N or the regional lymph node spread, and M, which is the distant spread. And then you have various combinations of T, N, and M descriptors to form the stage groups from 1 to 4. Treatment decisions are typically based on stage groups, but you have to sometimes factor in the individual T, N, and M descriptors also. And this is a summary of the individual, entire TNM stage grouping from T1A to T4, N0 to N3, and from M1A to M1C. And as you can see, you go from 1A1 to 4B, which is the highest. And obviously, the purpose of this is to prognosticate. And as you can see, the survival in the 8th TNM, the best survival is for 1A1 disease, and the worst is for 4B. This is true whether you look at clinical staging or pathological staging, and this ranges from 92% 5-year survival down to 0% 5-year survival for 4B. And a similar big difference if you look at the pathological staging. But there are potential lacunae in the 8th TNM, and this is largely related to heterogeneity of data. So this was presented by Dr. Frank Detterbeck, who is a surgeon from the US, And this was during our last meeting at the Staging and Prognostic Factors Committee at Barcelona last year, 2019. So as you can see, if you look at the database, for the T descriptors, most of the data is from pathological staging. However, for nodal disease, it is mostly from clinical. And for metastatic, there's only a small number of patients which are all clinical, which is obvious. If you look at the group descriptions, the majority is still pathological data, and a smaller number is clinical data. So there is heterogeneity both for TNM descriptors and for the groups. Now, if you look at how these cases were contributed during this 10-year period of the 8th database, you can see that Japan contributed in spurts, 99, then after a 3-year gap, another spurt of cases, and then another spurt of cases, and then nothing after that. And then there were people who were very regular, contributing regularly throughout this time period, and then another spurt by another institution in between. So there has been a lot of heterogeneity. What is the implication? The implication is that in addition to this heterogeneity, we have heterogeneity because these data come from consortia, from registry, surgical series. You have multimodality treatments, most commonly being surgical, 58%, but also 30% received chemo, and a much smaller percent received radiation. And then breakdown area-wise, mostly from Europe and Asia, and a very small contribution from North America or South America or Australia. Histological type, obviously, mixture of adeno, squamous, and other cell types. But the thing is, there has been significant variation in this survival based upon the area from which data was submitted. So as you can see, for N0, N1, or N2, based upon from where the data was submitted, there was differences in survival. Similarly, we know that there have been major improvements in survival between the 7th database and the 8th database. And if you look at 5-year survival rates for all stages, whether it is clinical or pathological, the 8th TNM, which is represented by the yellow bars, had much better survival than the green. And that is clear cut right throughout. Now, if you go on to the T descriptors, we know, I mean, if you have two lesions with a mixed GGO and solid components, we know that the size of the component is the same, but the GGO component is different. So should they be assigned the same T stage or different? Because it's typically the solid component which contributes to T staging. Now, if you have interlobar pleural invasion, it is currently classified as T2A based on the concept that interlobar PL3 or interlobar pleural invasion is not an invasion to an adjacent structure or an organ. But it has been seen that survivor and interlobar invasion is actually similar to that of T3 disease. So should parietal pleural invasion be considered same as interlobar pleural invasion? We don't know. And that is one of the things which is going to be studied. Now, lot of...
Dr. Navneet?
Hello?
Dr. Navneet, we have only 3 minutes left. So please, if you can manage the time.
Okay, so
we have only 3 minutes.
But we started quite late. So a lot of things about N descriptors, and the direct extension of primary tumor is classified as lymph node metastasis, and in any other than regional it is classified distant mets. So this is the lymph nodal map. Now there have been some ambiguous borders in the CT. Most importantly, the lymph node station 1 includes both supraclavicular and infraclavicular disease. And there are other N descriptors which are of importance to surgeons. This was presented by Dr. Vatanbe again at the meeting, and a lot of these things are very important to consider. In the interest of time, I'll skip these. But important thing is, if you compare N1A, which is a single N1 station, N1B, multiple N1 stations, single N2 station without N1 called skip N2, single N2 station with N1, and multiple N2 stations, you look at the survival is different. And so the best is for us N1 single followed by single N2, and then multiple N1, then single N2 with N1, and then multiple N2. But they will be more studied in the 9th. And then for metastatic, if you have presence of both pleural and pericardial effusion, does it have worse survival than only either of the two? If you have effusion present but not aspirated, can you classify it as malignant? If we have an exudative effusion with 1 or 2 cytology negatives, what do you do with that? And does the size, number of metastatic lesions, and the sites of metastasis matter or not? And then there are optional descriptors like lymphatic invasion, venous invasion, and residual tumor invasion, which are used after surgical resection, but they are optional. There is also something known as lymphangitis, which we wrote a letter a few years back, can be clubbed or believed to be the same as the nodules, the David's club nodules. Again, this is something which is being studied. And the main aim is that currently the TNM is purely anatomic with more relevance for early stages. But we also know that EGFR, ALK and other things are relevant in a metastatic setting and advanced setting. So the aim is to have a better system which is applicable for both anatomic and better for both early stage and late stage, and incorporates both the anatomic and the biological variability. And simultaneously, we are moving to a concept of essential TNM, where even if you don't have all the data, you can still qualify it as distant, regional extensive, regional limited, localized advanced, localized limited. And this is the proposal how to go about it. But this is all work in progress, and accurate staging means accurate treatment. Accurate staging means potential resectable patients getting surgery and lives saved. And therefore the ISLC has given a call for participation. And I'm pleased to announce we are the first center in South Asia to contribute cases to this database. And it's a very comprehensive data entry, takes at least 30 to 45 minutes for each entry. And ultimately we aim to have all green and no queries at the end of data entry. And ultimately, I'd like to say this is a multidisciplinary approach, and I'd like to thank all the people whom I've been working with during this time period. Thank you.
Thank you very much, Dr. Navneet. And we are very sorry because of short of time. So both of you could not present your lecture properly. I know it. But thank you very much. It was an excellent, indeed excellent presentation. Both Dr. Vikas Talreja as well as Dr. Navneet. Thank you very much. Okay. Now here is the end of this session. Okay, Dr.
Thank you, Chairperson. Thank you, sir. Thank you so much for your kind presence. Thank you, speakers. It was a wonderful session. So now we will move to Hall A for keynote lectures. I request the faculty members to log out from this Zoom meeting, and then you please log into Hall A. And attendees can also, from the bottom bar, they can also switch over to Hall A directly. So we'll be again meeting at 6 o'clock for next session.
Okay, thank you.
Thank you, Parikshit.
Okay. Okay, ma'am. Welcome. Welcome back to Hall B. So now we'll be restarting with the sessions. And for the next session, I would like to invite our chairperson, Dr. Sudhir Chaudhary. Am I audible? Chaudhary Salman Rathod. He is a past president of Indian Chess Society. Dr. Ajay Lal, I think he has not joined, but he'll be joining in a short while. So I invite Dr. Sudhir Chaudhary. Sir, please, can you please take over for the next session and invite the speaker? Dr. Sudhir Chaudhary, please. Sir, you there? I think he has not joined. Good evening, everyone. So we'll be starting with the next session. And now we'll be starting the next sessions for the chairperson for the next session are not here yet. So I invite Dr. Charu and Dr. Shubham Jain as chairpersons. Our respective chairpersons will be joining in a short while. So Dr. Charu and Dr. Shubham Jain, please take over the stage and invite the speaker for the next session, please.
Okay, good afternoon, everyone. I would like to invite Dr. T. Balamugesh from Vellore, and he is basically going to talk about how tuberculosis masquerades as lung cancer and delays diagnosis. I think every one of us in our daily practice, encounter this day in and day out. So I think he is going to help us out and, will throw some light on this very burning issue. Over to you, Dr. T. Balamugesh.
Thank you. I'll share my screen.
We can see your screen.
Okay, am I audible?
Yes.
Enough?
Yes.
Okay. Good evening and First of all, I would like to thank the organizers for giving me this opportunity to talk about how tuberculosis masquerades as lung cancer and delays diagnosis. I bring greetings to all of you from Christian Medical College, Vellore. Tuberculosis and lung cancer are two important diseases, and their association can be discussed in the following headings. One is both TB and malignancy can coexist by just coincidence. Second is TB infections can predispose to development of lung cancer. Third is lung cancer per se can predispose to tuberculosis. Mainly, the mechanism is chemotherapy-induced immunosuppression, which predispose to development of tuberculosis. And fourthly, there are similarities, clinical as well as radiological similarities between tuberculosis and lung cancer, and this can result in misdiagnosis both ways. So first, both of them coexisting together just because of coincidence. They are common. Tuberculosis, the incident pooled prevalence of bacteriologically positive pulmonary tuberculosis is nearly 300 per 1 lakh population. And lung cancer, although it is not as common as tuberculosis, their incidence rate is also high. So by mere coincidence, a single patient can have both of them together or in close time relationship with each other. Also, both of them have similar risk factors like smoking. For tuberculosis, smoking is a risk factor. In a meta-analysis, it has been found that the relative risk is 1.73, and for TB disease, the relative risk ranges from 2.3 to 2.7. For lung cancer, the risk due to smoking is much higher. It ranges from 6.99 in women to 7.33 in men. But the fact is, for both tuberculosis and lung cancer, there is a common risk factor of tobacco smoking. So if they can coexist with each other, then there are implications in the diagnosis. Because in a patient with tuberculosis, if the lung cancer has been coexisting and you miss the diagnosis and you go on treating only tuberculosis, that can have serious implications. The lung cancer, by the time you know that there is, in addition, lung cancer, it will already be metastasized and you will lose the early stages of lung cancer. Similarly, in a patient with lung cancer, if you don't diagnose that the patient has coexisting tuberculosis, if the patient is undergoing chemotherapy, there will be progression and dissemination of tuberculosis. So we need to understand that just because of mere coincidence and they are common, both can coexist. Coming to the second point of TB as a risk factor for lung cancer, the common terminology which is used is scar carcinoma. This was originally described in 1939 by Friedrich, and he described lung cancers which develop in peripheral scars. There are various mechanisms by which TB scars can lead on to lung cancer. One is by simple chronic inflammation. Not only TB scars, any scars due to UIP pattern of idiopathic pulmonary fibrosis or ILD due to connective tissue diseases, pulmonary infarction scars, all these can lead on to lung cancer. In addition, Mycobacterium tuberculosis per se can cause DNA damage, and it can also cause apoptosis inhibition, and this can add to the risk of them developing lung cancer in future. And typical teaching is these cancers are adenocarcinoma, but there are some series which say that even squamous cell carcinoma can develop as because of scars due to tuberculosis. And earlier there were a lot of literature favoring and against whether the terminology of scar carcinoma should be accepted. Is it a fact or a fiction, or is it a cause or an effect of a cancer? One school of thought was that the carcinoma per se can cause scars in that tumor itself or in the surrounding areas by a desmoplastic reaction. But when they studied in more detail, they found out that the collagen in the scars inside the cancer are type 3 collagen, which indicates that these are caused by recent fibrogenesis and not like the scars which are present, which will be present in post-TB scars or post-inflammatory scars, which are type 1 and type 5. But now there are a lot of studies which has confirmed that yes, TB scars can lead on to carcinoma. In one series, they found out that there is at least 1 in 5 patients who presented with lung cancer has a radiological evidence of scarring, and scarring was significantly more likely to be present in the same lobe as the tumor than in a different lobe, suggesting an association between scarring and lung cancer. There is another study which pooled data from 16 other studies as part of International Lung Cancer Consortium. And they found out that yes, tuberculosis is a risk factor for lung cancer with a relative risk of 1.48. And if we exclude people who were smokers, even then their risk remains high. The relative risk was 1.5. So there is no doubt that tuberculosis is a risk factor for lung cancer. And these particular cancers have a tendency for early lymph node metastasis and small vessel invasion, causing lower 4-year survival rate. We, from our institution, looked at people who presented with the lung cancer and whether they have been diagnosed as tuberculosis before they presented to our institution. And we found out that 29.2% of them has been previously misdiagnosed as tuberculosis, and hence they presented to our hospital with nearly 6 months delay. And that is very significant because by the time they presented to us, most of them were in stage 4 or stage 3B lung cancer, where curative intent treatment cannot be given. And that correlates with the many other studies from India that lung cancers are misdiagnosed as tuberculosis, and our patients with lung cancer are being unnecessarily treated with TB medicines, causing delay in the diagnosis and delay in treatment, and then leads to poor prognosis. And this group of patients, we found out that these patients have consulted an average of 2 physicians before they came to our center, and the final diagnosis of lung cancer was made. And we also found out that if these patients had initially gone to a pulmonary specialist, then the more likely that a delay was avoided. The second aspect is TB masquerading as malignancy. In a series of 89 case reports and 6 case series, in those people who had clinical and radiological features indicated malignant tumor, and then they did a biopsy, and the histopathology revealed mycobacterium. So they clinically and radiologically, it suggested cancer. They did a biopsy to establish the diagnosis of cancer, but surprisingly, they found out that patient actually had tuberculosis. And majority of these case series, they reported that it is more common in genital or peritoneal tuberculosis. So a misdiagnosis can happen both ways. A patient with tuberculosis, you can misdiagnose that he has malignancy, or a patient with malignancy, you can misdiagnose that patient has actually tuberculosis. So we have to be aware of that. So why is this happening? Is this because the history is common. The history, the clinical features are common, and both lung cancer and tuberculosis has parenchymal symptoms. But there can be subtle differences, like if the patients have mediastinal symptoms, signs of collapse or mass, clubbing, metastatic or non-metastatic manifestation, then our suspicion of lung cancer should go up. But this is not foolproof. tuberculosis can present with SVC obstruction or hoarseness of voice. So we need additional proof of the diagnosis. Can we rely on radiology? No, unfortunately, 1/3 of TB patients in adult population can have atypical chest X-ray or CT features for pulmonary tuberculosis. So we can solely rely on a chest X-ray and CT scan to say whether it is tuberculosis or lung cancer. Can we rely on PET scan? Again, the answer is no, because both tuberculosis and lung cancer can have PET positivity or SUV positivity. And this study in a high prevalence study country in Brazil found out that even when they use SUV max of more than 5, the specificity of diagnosing malignancy is remained low, 0.79, with a positive predictive value of only 54. So you can't rely on PET alone to differentiate between tuberculosis and lung cancer. So how to avoid misdiagnosis?
Sorry to interrupt, Dr. Bala. You have 2 minutes left with you.
Yeah. So how to avoid misdiagnosis? Always rely on a microbiological diagnosis of TB. Avoid the terminology of sputum negative TB. Use the modalities available, gene expert or other methods to diagnose microbiologically tuberculosis. If it is a cancer, try to get a histopathology, and presence of one does not rule out other disease. So the take-home message is we have to be aware of the varied manifestations of tuberculosis and lung cancer, and we need to maintain a high index of suspicion that both of them can present together, or one can lead on to the another. And at any point of time, if we see that a TB patient is not responding adequately to my treatment, or lung cancer is not responding as well to the expected treatment, our antenna should go up to see whether I am dealing with the other condition. Thank you for your kind listening.
Thank you, Dr. Bala. That was a really interesting presentation. We now move on to the next session for the day.
For the next session, I would like to invite Dr. Jaspriya, who is a nuclear medicine specialist at Max Hospital. And she is going to talk to the doctors of different specialities. And we have named it as All That Glitters Is Not Cancer, in conversation with the doctors with Halo. Over to you, Dr. Jaspriya.
Thank you, Dr. Charu. So in our session, we'll be having specialists from the various modalities. We have Dr. Nilendu Purandre, who's a radiologist at Tata Memorial Hospital with abundant experience in molecular imaging. Is my screen visible?
No, yeah, just where it's visible now.
Okay. We have with us Dr. Kinjal, who's a radiation oncologist at HCG Ahmedabad. We have our thoracic surgeon, Dr. Harshvardhan.
Good evening. Good evening, everyone.
Dr. Suryakant. I don't see him.
Dr. Suryakant sir is just joining. He's having some technical difficulties at his end. He'll just join shortly.
All right. So shall we start with the case then?
Yes, please.
Shubham, yeah, back to my screen. So we'll be discussing, taking forward what Dr. Balabudhish just said. We just have a practical experience with the same. We have a patient who was a 59 years old male who presented to the OPD with complaints of loose motions, anorexia, dyspnea on exertion, which was worsening since 15 days, upper backache, which was controlled on medications but worsening gradually. He didn't give any complaints of, didn't give any history of complaints of headaches or any bony pains. In personal history, he was a smoker, average 3-pack years, alcoholic since 30 years, diabetic, hypertensive, GC was average, COPD status was unknown. He presented to the OPD with an MRI spine, which showed a large mass in the right lung upper lobe extending into the mediastinum with involvement of T1 nerve root brachial plexus. It was encasing the right divisions and cords, probably explaining the pain. Dr. Harshvardhan, what would be your next steps for workup of the patient? Generally, such kind of patient presents to the surgeons.
If this kind of patient presents to me, the imaging modality present, which is present with the patient, I will evaluate that imaging modality, whether it's a CT scan or something. If the patient is having a detailed CT scan, I'll discuss it with my radiologist, and then go for something which will give me more insight in what the diagnosis is and where I can biopsy that patient. So my next step would be to get a PET scan of that patient.
So in such cases where there's a high suspicion, you prefer PET CT before getting
Before,
biopsy done?
yes, yes.
Okay. So we had a PET CT done, which showed a metabolically active large mass in the apical posterior segments of the right lung upper lobe. It was eroding the second rib, D1, D2 vertebrae, attenuating the bronchus. Apart from that, there were multiple metabolically active infiltrates in both the lungs, plus metabolically active mediastinal nodes. A CT-guided biopsy from the active part of the mass was done, which showed poorly differentiated carcinoma, which favored non-small cell lung cancer. So, Dr. Nilendu, you have the images. What would be your interpretation?
Okay, can you hear me?
Yeah, we can hear you.
Yeah, so there are these 3 sections of fusion PET CT scans which are provided, and there is a coronal fused PET CT which shows a large FDG avid mass, in the upper lobe of the right lung with a central area of cavitation or necrosis. As you said, it seems to be involving the superior sulcus or the lung apex or the thoracic inlet, and I can't exactly see the bone windows, but it seems to be involving the paravertebral region. But since the MRI also showed that, I would presume that it's involving the paravertebral region. So there is an extension into the extrathoracic space. There are some FDG avid mediastinal lymph nodes also, probably N2, and I can see some FDG avidity on the contralateral side as well. So probably this makes it a definite T4 N2/N3 lesion. And I can see, some tiny nodular opacities, as you mentioned in your findings, bilaterally, but it's difficult to, characterize what they are. We need a detailed kind of a evaluation of the CT scan, but few of them look to be kind of endobronchial branching opacities. But here I am not very sure whether these are bilateral lung metastases or whether these are just post obstructive changes in the lungs, like post obstructive bronchiolitis. I'm not very certain, but these two would be my differentials for the lung opacities.
So you will keep metastatic nodules as one of the differentials in this case?
I would have a very close look at the CT chest component. We, in our PET CT protocol, we do take a breath hold dedicated CT scan of the chest with high resolution, precisely for this reason, because if you have these tiny nodules with coexisting infections, we really need to characterize them properly. And here PET really doesn't help if the nodules are very tiny. We really need to look at their characteristic CT appearance. So very often infections, or particularly in centrally situated lung masses, with hilar lymph nodes, there can be, blockage of the airway, and we often do see post-obstructive changes in the lungs also. But yeah, I mean, METs would also be a DD simply because I'm not able to see it very clearly on this particular scan. But I leave it to you how you have characterized these and go by that.
Yeah. So just to proceed with the case, there were no left hilar nodes. There was only a hilar node on the right side. The subcarinal node was also not avid. So
Okay.
should we still suspect obstructive bronchiolitis on the left side?
If you're saying that, there was nothing which was kind of blocking the airway, there was no big subcarinal lymph nodes, though I can see some soft tissue, but then in that case, then
there is a subcarinal that's not avid. There is a subcarinal
okay.
node.
So there is kind of, whether it's not avid, but there is some kind of compression of the airway, then this also would be something at the back of my mind. But I guess your entire treatment hinges upon what these nodules are. We are quite clear about what is the T stage and what is the N stage. So, I mean, these two would be my only, infection or post-obstructive changes versus metastases. So I leave it to your expertise to kind of.
So would you advise any other further investigation to actually characterize these nodules, because they will change the entire management?
It's only the HRCT or high resolution imaging of the lungs, or probably an FOB and or a lavage or something, if it kind of shows up some infection or something like that. But beyond that, beyond imaging, I don't see any other, beyond a PET CT or a CT chest, I don't see any other imaging which can resolve this this issue.
Yeah. The burning question: how much do you rely on the SUV of the mediastinal lymph nodes to say them that they are involved?
Involved by malignancy? Okay.
By malignancy.
So we actually, there have been several papers, or there's a lot of data in literature which have come at various cutoffs. Even we have in our experience certain SUV cutoffs, but honestly, FDG uptake really doesn't get you anywhere. An FDG avid node can very well be infectious or granulomatous or tuberculous. So, and there is a significant overlap in FDG uptake of tuberculous lymph nodes and malignant lymph nodes. So I really do not rely on the intensity of FDG uptake seen visually, or even which is quantified in terms of SUV to decide whether the node is definitely malignant or no. We usually go in for some kind of an histopathological diagnosis, either by EBUS or TBNA, and eventually, if not, then by mediastinoscopy.
And anything just on CCT which can suggest about the characteristic of the mediastinal lymph nodes in particular?
So, very often on CT, people say that if you see necrosis, then it's more likely to be tuberculosis, but you do see necrosis even in squamous cancers. So that's really not very helpful. What we have found useful is, a definite evidence of calcification in lymph node. If the node is densely calcified, or if it has a significantly high Hounsfield units, they're more likely to be granulomatous, irrespective of whether there is FDG uptake or no. From our own database of around 400 patients, when we have used the criteria of calcification or Hounsfield units, the specificity of PET has jumped up by around 20%. So presence of calcification or a high density of the lymph node on CT scan, improves the specificity of PET scan. But other features, if the calcification is not there, then merely presence of necrosis it can't really, differentiate between a malignant or a tuberculous lymph node.
Dr. Harshvardhan, question for you. How much do you rely on FDG PET-CT for initial staging in the lung cancers, suspected lung cancer?
just to give the thing that we see whether the nodes are lighting up or not. So we divide it into PET positive or PET negative. If the nodes are lighting up, then we definitely go for a some histopathological diagnosis by the way of an EBUS or a mediastinoscopy or whatever means we think are possible. Because in practice, we have seen that uh, our data of 137 patients, which has been analyzed by one of my PGs, it has been seen that 9.2% of the nodes were tubercular. And the false positive rate of this PET scan turning out, we thought that it would be malignancy, was something like 18 point something percent. So there is a lot of this false positivity of we thinking that this node would be of positive because of its avidity and lighting up, and it turns out to be a tubercular or some infective pathology, particularly in Indian scenario. So we always go for a histopathological diagnosis in PET positive nodes.
Dr. Kinjal,
yes.
to you. So what next? What would you like to do next? Any other investigations, tests?
No, I think majority of the tests are done. We would just do because this is a patient who will be going for chemotherapy. So I think we would just do a pulmonary function test and maybe a echocardiography just to know the status of fitness of the patient to put him on chemo.
All right. So this patient, as of now, he is a candidate for chemotherapy.
Yes.
Any role of radiation in this patient?
No, I don't think any role of radiotherapy in the beginning right now. But if the patient's pain is too much because the T1 nerve roots were compressed, we can think of a palliative radiotherapy for pain relief. But I would not be too keen to do it because let the chemotherapy work. If it is not working, maybe after 2 cycles and pain increases, then we can think of radiotherapy at that time. So I would definitely refer this patient to my medical oncology colleagues.
Okay, so that was the same thing which was done here as well. The patient was referred to the medical oncologist, and he received 3 cycles of chemotherapy with pemetrexed plus carboplatin plus Avastin. So after 3 cycles of chemotherapy, the mass showed a significant reduction in size and FDG avidity. The nodular infiltrates which were there in both the lungs, they had disappeared. The mediastinal lymph nodes actually increased in FDG avidity. Apart from that, there were some non-specific nodes in the left cervical regions as well. So this was the scan after 3 cycles of chemotherapy. The mass showed a very good response, and now we can see a subcarinal node which is actually lighting up. Dr. Nilendu?
Yes, you are seeing a lymph node there in the subcarinal lesion. You can see that the mass has significantly regressed, and even the lung opacities have significantly gone down. That's kind of an indirect proof that they probably were metastases and have responded to chemotherapy.
So that was our final conclusion as well. So what all are the response criteria that you use for patients on chemotherapy?
So, I mean, you have you can use, there are several response criteria defined in literature. You can just go by visual criteria. You can use your SUV max, where you can use the EORTC criteria of reduction in SUV by around 25 to 30%. Classifies it as a partial response. You can use the PERSIST criteria also. We do not per se mention a specific criteria, but we just go by subjective and kind of a visual evaluation first. And we also look at the percentage drop in the SUV. And this definitely amounts to a partial response.
So, because we labeled this patient as N2 earlier, would we still stick to that considering the mediastinal nodes have actually increased in avidity?
So, that's, it's kind of, that raises the question where you have lung nodules which have regressed completely. You have such beautiful regression of the mass, but the nodes have actually progressed on chemotherapy. So, whether it brings us to the question whether we are dealing with a coexisting infective or granulomatous pathology, where often after initiation of chemotherapy, when the cancer regresses because of immune suppression or something like that, the infective changes which are coexisting probably flare up and are become more prominent on imaging. We see this quite often. So there is this possibility also now, because some mediastinal nodes have definitely gone up. But you can, the pre-existing nodes in the precarinal region, those which were there, they have kind of
gone down.
Yeah. Some nodes have gone down, some nodes have gone up. So I'm not very sure whether this is a kind of a differential response or we are dealing with a coexisted granulomatous pathology, which is now flared up after chemotherapy. So these two possibilities remain.
So Dr. Kinjal, if we disregard the metastatic nodules, if in such kind of a patient, if you would want to take the patient for a definitive radiotherapy, how do you go about the mediastinal nodes in such a scenario where some have increased, some have decreased? What would be your next step?
Yeah, so this is a common scenario which we see for our head and neck patients also. The head and neck patients present with a mediastinal node, or maybe a lung or an esophagus patient with mediastinal nodes. And just like what Dr. Harshvardhan had said earlier, we would definitely prefer doing EBUS guided biopsy and or a mediastinoscopy and prove it whether it is a positive node or not. As far as the radiotherapy for such a patient is concerned, earlier having nodules of lungs gone, I don't think is a candidate for radiotherapy. But if there were no nodules in the lung and the patient presented only with a T4 tumor and the mediastinal nodes, and the way the response is seen, this patient can be taken up for concurrent chemoradiotherapy. I mean, if the nodules are not there. So if it was only a T4 N2, yes, we can treat this patient with radical chemoradiation. But I would again, looking at the picture, the middle picture, I would still feel that we can do an EBUS and try to find out whether this node is positive or not. Because now when we do radiotherapy planning, we do a PET-based radiotherapy planning for majority of our patients at big centers, and we treat only what glitters. Actually, the name of the scheme is also matching, because earlier we were treating the nodes in a big chain we were treating. Now we only treat the nodes which are involved. So for me also, just like a surgeon would like to know if the node is positive or not. So I would prefer doing a mediastinoscopy, EBUS, and see the nature of that node.
So apart from lung cancers, which other malignancies would you prefer doing an EBUS before treatment?
Head and neck, because I see a lot of head and neck patients. In Gujarat, we see a lot of tobacco chewers and smokers. So we see a lot of head and neck malignancy, and they do present on a PET with the mediastinal nodes. And we have burnt our hands. I'm talking about 15, 20 years back. We had a patient, and patient had to go to Tata for a PET CT, got a PET CT done, and it was showing mediastinal nodes. Patient was offered palliative chemotherapy. After 3 cycles, primary was gone, and the mediastinal node was still there. And then we thought, we burned our fingers. We wasted the patient's time for 3 months. Then we got a mediastinoscopy, biopsy was showing tuberculosis. So for head and neck, it is a highly suspicious that it may be, not positive, maybe a granulomatous or an infective node.
So Dr. Nilendu, which mediastinal lymph nodal stations would raise more suspicion for a malignancy and which will raise more suspicion for being just granulomatous?
It's actually more of a theoretical thing, but you can get tuberculous nodes all over the place. Usually in what we do say, as Kinjal said, in head and neck patients, we often see them in the right 2R and 4R regions. You often see lymph nodes in that area. There's a certain pattern described, bilateral, hilar, paratracheal lymph nodes. When you see a classical PET pattern, which is like, bilateral hilar nodes you have in the right paratracheal stripe. Very often in our experience, when a EBUS or mediastinoscopy is done, those turn out to be granulomatous. But I wouldn't say there's a very hard and fast rule that from the location, we can be certain that certain location would be because of malignancy and certain locations would be because of granulomatous disease. EBUS, some kind of an histopathological correlation would definitely be warranted. as he said, we have also burnt our fingers. We have tried everything possible. We have tried SUV. We have tried using CT criteria. We have tried to take ratios. Nothing seems to work out very definitively in characterizing mediastinal lymph nodes. It eventually has to go for some kind of histopathological evaluation.
And as I understand, like we have also experienced, there's no correlation of the SUV of the primary with the SUV of the mediastinal nodes. There's no
nothing works.
Nothing works.
Dr. Jaspriya, you have 3 minutes with you.
Yes, ma'am. So the patient was continued on the same chemotherapy. He came back with multiple bilateral lung infiltrates, there were some consolidations, which were as FDG avid as the primary mass. So Dr. Nilendu, what will be your differential now?
This is a really foxing case, but if I look at the lung windows, I can see a VY tree in bud kind of a pattern in the in the lungs and kind of an endobronchial disease spread. So I would with lymph nodes increasing and these kind of opacities, I would really try to prove or disprove a coexisting tuberculous infection, just because of the pattern of those lung changes which are happening there. Because anyways, if these are metastases, we are not going to do much further change. But if it's an endobronchial TB, then he really can be treated for that also.
So we have the differentials with us. The patient was subjected to a biopsy. It came as necrotizing granulomatous inflammation, and the patient was referred to pulmonologist. So my question would we like to restage the first scan?
Yeah, ideally we should.
I think so, yeah.
Yeah.
What could we have added to the workup, or
maybe maybe the EBUS done at the beginning. EBUS at the beginning would have definitely helped.
First scan in EBUS.
Yeah.
This would have been for mediastinal nodes. Anything for the lungs? I mean, or we would have taken lungs just as tubercular.
No, I think with a very doubtful picture in the lungs, I would have gone for a very diligent mediastinal staging. If few of them would have turned out to be tuberculous with this necrotizing granulomatous infection, then it changes the entire picture and staging. Then probably we would have not looked at the lung nodules so critically as malignant, and and would have changed our intent of treatment completely.
And Dr. Kinjal, does it change the intent of
treatment? So to begin with, if we had proven that it was a tuberculosis, we would have definitely given neoadjuvant chemo first. Like we would have started with chemo only. Maybe after 3 seconds with an excellent response, we would have gone with a chemo radiation at that time.
Okay. Yeah. So Dr. Harshwardhan, the last question. So do we do EBUS in all the patients?
So all PET positive mediastinal lymph nodes should be subjected to histopathological examination. The first step for a thoracic surgeon is to go for an EBUS where it is available. The availability should be there and expertise should be available. They should station at least, they should sample at least 3 stations in all the cases. If the expertise is not available, if the EBUS thing is not available in your hospital, then go for a mediastinoscopy and stage the mediastinum. But all PET positive these lesions should undergo some kind of staging, some kind of modality to be staged.
So we just can't take it on the face value. That
no, not at all.
Dr. Charu, so.
Thank you, Dr. Jaspriya, for bringing out an interesting case. And thank you, panelists, Dr. Harshwardhan, Dr. Nilendu, Dr. Kinjal, for having a real interesting discussion on such a case. We were really forced to handle this case, actually.
That's our practical experience.
Interesting case.
Yeah, interesting case. Yes.
Yeah.
Thank you
all.
Thank you.
Thank you so much.
Thank
you. Welcome, Dr. Sudhir from Lucknow. And sir, you are muted. So now we will, Dr. Sudhir, you are muted, sir. We can't hear you.
Again, try. Yeah. I'm Dr. Sudhir Chaudhary from GSVM Medical College, Kanpur.
Welcome,
And I missed only the early part because of some technical snag. Though I was watching you and listening very carefully, starting from Dr. Bala Mugesh and then your panel discussion. Well, I have come to a conclusion after that. It's truly very difficult. In fact, I was, from the pulmonologist point of view, I was just looking very carefully whether a small shadow, I mean a coin lesion or a 1 centimeter lesion, because in early stage surgery is usually the best answer. So if you do a surgery, it comes out to be granuloma or a infective, then it looks very embarrassing for the physician that they have gone for such a big procedure and ultimately it turned out to be a simple granuloma. So there should be some, we should work out for some specific signs in which we can definitely call it malignancy. We can definitely call for a infective. It's very difficult. I was just looking for a comprehensive account of what to say, what to teach. But I think ultimately everybody is focusing on histopathology, basically. So the time is not still very clear that we can be very sure in our diagnosis. So any comments, Charu?
Yes, very, very true, Dr. Sudhir, especially in a country like India, where we very often we see tuberculosis and lung cancer coexisting. So, I mean, and then handling those patients becomes really difficult. Managing chemo, radiation, and AKT all together becomes a huge task for us. And which, like in future, we really have something, which can differentiate really apart from the histopathology. At times, you're not able to do in a resource-constrained country to do EBUS or mediastinoscopy every time. But apart from that, we really don't have anything else to differentiate.
Well, if something, a review is a registry or if a review is done of around 1,000 cases in which small shadows are there. So in that, what we thought and what it turned out. If a group is made in which we can present our cases from the beginning, what was thought and what it turned out. This will be a good learning point in future.
Very,
I think we should work for that.
We should work, yes.
The president should initiate this, something like that.
Very true, sir.
Thank you.
So,
thank you.
So we would move on to the next lecture of the day, which is understanding survival statistics for lung cancer. And this was to be delivered by Dr. Purvish Parekh from Mumbai. But because of certain reasons, he's not here. But he has sent us a recorded presentation of his, which our technical team would play. Shalu or Pankaj, you can please start the presentation.
Thanking Dr. Nitesh Sohati and Dr. Navneet Singh for giving me this opportunity to be part of NALCON. My topic is how to interpret survival curve. And I believe that this assignment has been given to me because I am either editor or editor-in-chief of the 5 journals that you'll see below. So let's start by a visual image. In the tank that you see here, in the top 2 images, the turrets are going upwards, and the bottom 2, the turrets are going down. So what is the reason for this? Any person with a armed forces background will know that the top 2 tanks are Indian tanks, so their head is held high, whereas the bottom 2 tanks are enemy tanks that we have captured, and therefore their head is looking down. Now this is the interpretation skill. 4 years ago in Hindustan Times, this statement was made that global mental illness, a third of that is seen in India and China. And what is such a great thing about this heading? How misleading the heading can be. Because 1/3 of illness in India and China actually represents the 1/3 or 36% of the population that resides in our country. Now let us look at this image of strike that paralyzes part of India. And you can see that somebody is trying to smash the motorcycles of people who are on the road. But if you take a closer look, you will see that all the people on the motorcycles are smiling. And this really tells you how breaking news is faked. And this is actually a fake photograph. So we should always be careful about what is hidden when we look at survival analysis. Now, survival curve analysis is nothing new. Okay, the first one that I could identify was way back in 1669 about how 100 people would have survived up to the age of 86. So why are we using survival analysis? The first is, why not compare mean time to event between your group using a t-test or a linear regression? If we do that, we ignore census. So why not compare proportion of events in your group using risk odds ratio or logistic regression? And this ignores time. So these two are not the way to do it. So we normally use a Kaplan-Meier survival curve. Now in the Kaplan-Meier curve, you will see that there are a drop in the curve. Now each drop in this curve represents an event. Okay, all of us know that, right? Now every event leads to a drop, but what are not considered an event and therefore will not show up as a drop are lost to follow-up and end of study. So patients who do not have an event are considered censored, which is random right censoring. And therefore we know that they survived at least a specific amount of time, but do not know the exact time of the event of their survival after the specific time of the study. Now look at what do we now see from this curve. The drop in the curve occurs after every event, and between events, the estimated survival remains constant. That means the line is horizontal. Survival curve does not drop at censored time. That is, for instance, lost to follow. But the size of the drop changes after censoring. So after each person is censored, the next event will lead to a bigger drop. And I think this is something that not many people understand. What follow-up time is not an event, curve does not go to zero. So in the solid line, you can see that there are 4 patients who are lost to follow-up. They may be dead, but if you look at the graph, it will show a 40% overall survival. And these 4 censored people are shown in the red arrows in the enlarged portion. So this is an important thing that we should keep in mind, how it can be misleading. Also, we should pay attention to confidence intervals. That is 2 standard deviations or 95% confidence interval that can be placed by Greenwood's formula on either side of the survival curve line. Now let us see what is unique in some 3 examples that I've taken. Here you have a study arm which is in dark color and a standard arm or the control group which is in gray color. Now you see the end of the line. In the study arm, the line ends at about 19 years, whereas in the control arm, the line ends at 29 years. Whenever you see the end of the line is different like this, even though the p-value is 0.001, you know that this is a historical control and therefore it has to be taken with a pinch of salt. What about this? Here you see that the survival curves are crossing, and in this instance it is probably at 6 months. Now whenever you see something like this, and I see that in the lower curve at the beginning, it represents a more intensive treatment that because of its intensity causes early mortality. But if the patient goes beyond the early mortality, then he has a plateau and therefore there is a chance of cure. On the other side, there is the other curve which shows a constant downward trend without a plateau. So there is a trade-off of intensive treatment which increases early mortality but gives a better chance of cure. So this is what the curve represents. Now this is similar to the curve that I showed you earlier. And here, for the first time, you will see that the number of patients at risk is mentioned below the x-axis. And you can see that after 15 months or after 10 months, you can see that the number of patients at risk are in single digits. This tells you that the survival curve is actually not reliable once the patients at risk in each arm come to single digits. Therefore, only what is shown at 10 months is something that is worth following. After that, whatever has happened could be by chance. Now, for the second part, I will show you some examples from lung cancer. And I've deliberately taken curves from older studies so that I do not take away the thunder from the other faculty who are going to present you the data that is ongoing. Now, this is Lux Lung 3 and Lux Lung 6. And here again, I want you to focus on the number of patients at risk. In Lux Lung 3, single digits start at 39 months, and in Lux Lung 6, the single digits start at 36 months. So if you see the graphs before 39 months on the left side and before 36 months on the right side, you will see that the separation is continuous, consistent, and is increasing further. So in both these instances, even though the visual impression is different, I would interpret this as showing a good response that is consistent and is separation is increasing as the time goes on. Now that was overall survival. This is progression-free survival. On the right side is the whole group, on the left side is deletion 19. And you must be careful when you have a subset analysis like this. Fortunately, in this instance, the degree of separation and the continuous separation is there in both the arms. And therefore, what is seen in deletion 19 is also seen in the whole group. Having said that, we should also know how many patients from the whole group had actual deletion 19. For instance, if deletion 19 was seen in 80% of the patients in the whole group, then that might actually influence how the whole group graph is seen, and that should be kept in mind. Of course, in this particular instance, the difference, absolute difference, is so startling at 1 year that there is no reason to doubt that the p-value is highly statistically and clinically significant. Now, this is patients with brain metastasis. And here I wanted to point out another aspect where combined analysis of two studies are being done. Whenever you have a rare disease or you have a rare occurrence, there might be a need for combined analysis. But this combined analysis is like comparing apples to oranges, and therefore this difference, which is statistically significant, should be taken with a pinch of salt, especially since after 12 months, the number of patients at risk are really small. Now we come to when the curve starts separation, and this is progression-free survival between afatinib and gefitinib, that you can see that the curve starts separating after the median survival is reached. And this is very interesting. Now, why this happens? This could probably happen because we have not enriched the population that benefits the most, and therefore it takes a while before the effect on the responding patients is seen. Fortunately, if you look at this graph at 18 months and 24 months, you can clearly see that the separation is consistent and the separation is continuing. After that, when the patients at risk is in single digits, the graphs start coming closer to each other, but this should not be interpreted as reduction in the outcome. This separation after the median is not only for patients who are getting TKIs, but you can see that the same thing is also seen in patients who are receiving immune checkpoint inhibition. In both these instances, once we have a better biomarker, once we can identify the patients who are most likely to respond earlier, we will have the separation earlier and we would be able to select the patient properly. Now, DIAS is, instead of looking at overall survival or progression-free survival, this is time to treatment failure. And this could be when the patients are continuing on the treatment even beyond the normal RECIST criteria, and they will continue till they become symptomatic or as long as they have stable disease. Here also there is a reduction in the risk, and you can again see that at 24 months and at 30 months, there are sufficient patients at risk to say that this data is valuable. And after that, when the curves come together, there are hardly a handful of patients, and that part should not be considered while we interpret the result. And this is why in this instance, the p-value is highly statistically significant of 0.007. Now I move on to some of the new things. So often we say that the patient's response to a study arm is not showing overall survival difference because of the beneficial effects of subsequent lines of therapy. Now the people in UK Leeds have come up with a solution for that. And this new method is available to adjust survival curves and remove the confounding effects of subsequent therapy. This can be done for up to 6 lines of therapy. Can you imagine that? And this is not new. This was published in 2012, that the impact of 2nd to 6th line therapy on survival has been clearly identified. There is also the confusion or problem of converging or crossing curves, and the statisticians have been smart enough to identify a solution for that as well. And you can see that at primary analysis, the p-value was not significant. It was 0.108. But after 1 year additional follow-up, the hazard ratio became 0.82, and the p-value really became significant, 0.03. And this, in fact, allowed the regulatory authorities in Europe to give marketing approval for this particular drug. So there are new ways of interpreting the survival curves in a much better. For those who are initiated in doing things on their own, I would like to end by showing you that it is possible for you to draw survival curves from your data using Excel. And this is a very simple 6 easy step method of using Excel files to develop your own survival curves for your presentation as well as for your publication. With that, I thank you very much for a patient hearing, and I wish all the best for the rest of the conference.
I think that was a wonderful lecture, letting us into the survival curves and, you know, their interpretations. So with that, we will close this session here. Any words from Dr. Sudhir Chaudhary? And then we would move to Hall A for the inauguration. Dr. Sudhir?
No, I have nothing to say. It's above my head, actually. The statistics basically was above my head, and I'm sorry I cannot comment on this.
That's perfectly fine.
Maybe you can put some comment on that. Thank you.
Sir. No, so that was actually a very nice lecture, and you know, telling us what the survival curves at times, what we read, and you know, basically reading between the lines in the curves. So I think that was a wonderful lecture, and now I would request everyone to join us in Hall A for the inauguration.
Okay.
Thank you.